This episode is brought to you by Wagon Maker and Oberly. Wagon Maker and Oberly has been providing legal counsel to nonprofit organizations for over a decade. Their practice is founded upon commitments to deliver high-quality work product and a transparent billing process, to treat clients with integrity while faithfully advocating for their best interests, and to strengthen the nonprofit sector by fully engaging with the communities they serve. To learn more, visit wagonmakerlaw.com.
Welcome to the IndeDocs podcast. Today, we're sharing part 2 of a 2-episode conversation with Dr. Arlen Meyers. If you missed part 1, you can find it linked in the description and on IndeDocs.com/podcast. A quick disclaimer, we are sharing our personal opinions based on our own experiences. Therefore, nothing should be taken as professional legal, financial, or medical advice.
You're listening to the IndeDocs podcast, where we discuss important issues related to our mission to preserve, promote, and protect the practice of independent medicine. Thank you for tuning in.
One of the things that the systems are doing is they're getting bigger and bigger and bigger, in spite of the fact that the revenue streams are no longer the traditional revenue streams. I mean, clinical reimbursement, grants, those type of things are dropping, yet there's this giant expansion effort going on. What do you think that can potentially lead to? I mean, do you see I like the analogy of the too big to fail experiment with the banks, where these systems are, taking on massive amounts of debt, yet their income stream is going down and is not really supporting what they're spending, because they're in these sort of favored positions within the states. They're very important to the state economy and all that. But do you see that as a potential crisis or a potential issue?
Well, it already has been. I mean, consolidation and corporatization and financialization of the system has already created multiple problems. Just ask any patient, about their experience, whether it's prior authorization or out of network or surprise billing or et cetera, et cetera. So we're already seeing that. And Medicare has just announced that they're going to try an experiment with prior authorization as well. So if anything, things are getting more difficult. The sick care system is getting sicker. And that is leading to patient and physician dissatisfaction. Now, most, if not all of those things, I have a general rule, and it's, again, not mine, but the rules create ecosystems. The ecosystems create business models. The business models facilitate or interfere with our ability to achieve the sextuple aims. So if you're asking me, what can we do to right this ship, change the rules? That's the root cause. Now, that means health policy reform. That means changing universal coverage versus something else. That means all the reimbursement rules. And, are CPT codes really the right way to bill in this day and age? The AMA owns it and makes millions off of it. So, of course, they're going to say, don't mess with it. In fact, that's how they make most of their money. But, sure. Are all of these systems outdated and result in what we're seeing now? My argument would be yes. We don't have a healthcare system. We have a sick care system of systems that masquerades as a healthcare system. And oh, by the way, 96% of the 5.6 estimated to go to 6 trillion in the US healthcare spend goes to taking care of sick people, not preventing illness. And it's getting worse because all you have to do is pick up the newspaper. The public health infrastructure is crumbling. So if anything, I mean, these are just things that have to be fixed at the health policy level. We can only do so much about this because it's a trickle effect.
Well, that's actually what I was going to say, is that so that is where my interests have sort of bifurcated. There's the system problem, all of which you've enumerated. My interests have been lately, or in the last several years, decade maybe, is to actually offering alternatives to the systems, doing things that would allow physicians and patients to have options out of these, the big healthcare systems, the consolidated, vertically integrated, systems. Which brings us kind of back to, the independent practice of medicine. So to me, the legislative things and policy things that we've been able to achieve in South Carolina, the point of that is to open the doors for physicians and patients to do something different, right? So now it takes the public to be demanding that they want a better experience, that they rather see their doctor rather than a, mid-level provider, quote unquote, or, be in a small waiting area as opposed to, a large lobby where they're taking a number and being called. And for the physicians to take advantage of the fact that these doors are opening, so where is your interest in? Is it more in the trying to change the system, or is it trying to open the doors and direct people to alternatives to the system if the system is so bad?
My emphasis is on making the present, training and inspiring graduates to make the present system obsolete. So I can only do what I can, think I have some influence in. I mean, I'm not running for Congress. I'm not running for all that. I'm just kind of trying to stay in my lane, to use the metaphor, and do what I can do to try to inspire people. Now, the good news is the system is so screwed up that it is ripe for the taking.
100% agree. Yep.
All that stuff, the disruptive innovation theory and the destructive, all that stuff. So, and you're seeing that happening, whether it's just very small pieces like value-based surgical care, like direct primary care, like various employer-based insurance like bundled pricing in a surgery center, little by little. So I think this is going to happen through the physician entrepreneur. It's an example of how to change the system. More importantly, ultimately, it's going to come down to, I think, a public uproar. I think patience, because when you look at, theories of social change and how these things happen, this doesn't happen because, there's one person that says we should do it. It happens because you get millions of people who get pissed off and want to make a difference. I don't care if it's gun control or how we pay for healthcare. Eventually, people are going to get angry and they're going to change the rules and they're going to throw the bums out. We'll see. But that's how I think it's going to work.
So I'm sitting here nodding my head, even though we're on an audio podcast, but agreeing. But so tell us a little bit about what SoPE does and what are some of the steps that you've been involved in and in trying to affect some of these changes.
Sure. So the Society of Physician Entrepreneurs, affectionately referred to as SoPE, SoPE, is an international, nonprofit, open biomedical and clinical innovation and entrepreneurship ecosystem. What does all that mean? It means anybody can join. You don't have to be a healthcare professional or a sick care professional to be in the organization. Now, people say, well, why do you call it the Society of Physician Entrepreneurs if anybody can join? That's another story. It is what it is, and I'm not changing it. I'm just telling you that anybody can join. And what that means is the underlying hypothesis is that sick care cannot be fixed from inside. If it just had to do with doctors, it would be the blind leading the blind. It has to be fixed from inside out, outside in. What do I mean outside in? I mean other industries, aerospace, retail, commercials, any industry. I mean, I believe that a lot of the problems that we confront in sick care have already been solved by other industries. I mean, just look at it. Search, transportation, supply chain, aerospace, telecommunications, you name it. But we are so siloed that we are not good. I call this innovation and ovation because we don't accept outside in. Now, it has to be both. And I think one of the problems, if I call these non-sick care entrepreneurs, and the latest example or what I call entrepreneurs, AI entrepreneurs who think they have the secret sauce to fix sick care. They don't. And the usual problem is either they don't know what they don't know and they won't accept it, and they don't understand the ecosystem well enough and don't have the connections within medicine to truly understand the workflow and the mindset of the people who work there and the stakeholders. Now, that worked both ways. So part of the problem is that if, for the example of data AI getting into healthcare, it would be nice if doctors and data scientists could be bilingual without an accent. In other words, you don't need to know how to all the secret stuff in AI, but you have to know something to talk and collaborate with these folks and vice versa. So I just don't think that we do a good job of integrating. It gets back to my point that innovation silos are so rigid and industries are so rigid that it's difficult to have a decent conversation without screaming at each other.
So give me some examples of things that you've noticed within SoPE or that have come out of SoPE or interactions that you're.
Well, to take the point of artificial intelligence, I mean, we're pretty involved with a lot of strategic partners. Those strategic partners include medical device, drug discovery and development, data science, artificial intelligence, ed tech, all that stuff. So we try to get people who are different to get along in the same room. So essentially, what we are is an international dating service that is a cross between Rotary and Match.com. So if you have an idea and you are clueless how to get this thing over the goal line, how to get it to a patient, what we do is provide an ecosystem that you can connect to someone. We connect people who have questions with people who have answers. And they don't come from the same industries. So you have to have this open growth mindset that is discordant. In other words, you fill a bunch of stuff from all different places into the funnel, and eventually it moves through the funnel till you get to concordant thinking where you have the right strategy and tactics to succeed. And incidentally, when this takes to take all of this into private practice and medical practice entrepreneurship, in order to grow one of those things, in my view, it comes down to people, strategy, execution, and money. And what we are talking about is how to execute on those things. Strategy without execution is a hallucination. So you have to get it done. It's not good enough to just learn about it in school.
So can you give me a concrete program or project or something that came out of this type of collaborative?
Well, each industry. So again, if biomedicine and clinical innovation is a big ocean. So you basically divide it up into drugs, in vitro testing, med tech, digital health, artificial intelligence, ed tech, those sorts of things. So if you divide the buckets into those subdomains of biomedicine, there are many, many examples in each, whether it's mRNA vaccines in drug discovery, the intersection of space medicine, which basically means how are we going to take care of people when we land them on Mars? How do you take care of people in space medically. And I'm having a collaboration, and there's a recent one where people are launching satellites, putting them in orbit, whether it's telecommunications, whether it's satellite digital health. And one application of that is, how do we develop new medicines in space? What does zero gravity offer that you can't do on Earth that would accelerate the drug discovery process? Another example, I mean, there's lots of examples with remote sensing and artificial intelligence and in silico testing, clinical trials, et cetera, et cetera. So all of these things are sort of, again, it's an ecosystem.
Taking it back down to the individual trainee, somebody who is in medical school, residency, how would you start in influencing them to start thinking in these ways?
Right. So the way I would do this is change the kinds of experiences that you offer pre-meds, particularly ones if they could work in a startup. I personally think that one of the major deficits in someone who is thinking about going into a private practice, that is a healthcare professional services business, is the inability to sell. Because so much of what private practitioners do is sales and marketing. It gets down to that old saying of, the two basic reasons for a business have to do with innovation and marketing, and everything else is a cost. So we don't expose people to those skills. So I would take a real close look at the people that we're taking into medical school. I would offer them sabbaticals. I would offer them rotations on startups. I would offer them rotations in a private practice environment. And, oh, by the way, I would offer them exit ramps. And by that I mean, you probably talk to med students just like I do. And when I say, how many of you want to go into private practice? 0. How many of you just want to see clinical patients for the rest of your clinical career? 0. They want to do more stuff than just see patients. They want to change the world. They want to fix the system. They want to create more purpose. Whatever you want to call it, they just don't want to see patients. They want to do more stuff. We don't give them that opportunity to learn how to do it. And what's more, about 6 to 10% of medical students never graduate. What do we do with them? We throw them out and we make them pariahs. Like you were a bad person because you filled a seat that somebody else could have got, and now you're quitting. That's not right. You got all these smart people that can contribute to the system. And you know what? They're going to go out and create a biotech company that will cure a whole hell of a lot more people than you or I have ever will. Yep. It's a bad cultural norm, and that needs to change. So what do I think? I think we should provide exit ramps. I think we should have, in some instances, if you're 2 years into med school and you say to yourself, you know what, this isn't what I signed up for, but I want to stay in healthcare, I think we should have a master's or a track or a professional science master's program in biomedical entrepreneurship. You've already been exposed to the ecosystem. Why spend the money going to to business school when we've just explained all that? Do it in the college, but offer a different exit ramp. Same thing with residents. 10% of residents are going to drop out and do something different. And, oh, by the way, a lot of medical students are now saying, I'm not even going to do a residency, particularly if you're in Silicon Valley, I'm going to go work for a startup.
Right.
Well, the problem with that is, A, you don't know anything about medicine just because you have MD after your name, and B, you don't know anything about business. So now you're going to go out and be an advisor to a startup. It just doesn't make sense. So I just think we have to rethink all of these elements to make it work. And it's eminently doable because a lot of places do it. In other words, why not have more industry, faculty, knowledge transfer programs? Take someone from Medtronic and make them a medical school faculty person, an adjunct, and teach them this stuff. And vice versa. Take a medical professor and put them in Medtronic for a year, or her. And there are programs around the world to do this. Actually, Europe, where I had the good fortune to spend some time doing this, they have much better knowledge transfer programs than we do. In fact, we don't have any. In fact, we discourage it because if you get in bed with industry, it's a conflict of interest. and you're taking money and you're on the speakers bureau and all that other crap. So it's a disincentive to do it.
We'll be right back after this break.
If you are a physician or an administrative professional working in a medical field in South Carolina, we invite you to consider joining the IndeDocs membership. Members have access to exclusive resources and networking opportunities and are an essential part of supporting our mission to preserve, protect, and promote the practice of independent medicine. For more information, please visit our website at IndeDocs.com. That's IndeDocs.com.
So going back to the three root causes, we've talked about the mindset, we've talked about the education or the failure of medical education in this realm. Systemically, what are some of the things that you think would be helpful to, again, force? And I have personal opinion. I mean, I've involved with three of them, eliminating certificate of need laws, trying to eliminate non-compete clauses, incentivizing charity care. But what are some systemic things that you think would be worthwhile pursuing to, as I think I remember you mentioning in one of our discussions, to building the shareholder value, right, of whatever it is that you're involved in?
Right. So, well, one obviously has to do with the corporatization of medicine and antitrust legislation. Two has to do with, obviously, healthcare insurance. Is it universal? How? Give it a name, call it whatever you want, but make it universal. And I'm not saying, because there are many, many different ways to do this, but it ultimately comes down to who gets insured and how. I mean, I don't have there's many ways to do this.
Sure.
The third has to do with money. So, one question is, how and how much should doctors be paid? Is it right that pick a specialty makes several $1 million a year and another specialty makes $300,000 a year? So that gets to the whole question of, are doctors paid too much? Well, I don't know. I mean, if you look at it internationally, I mean, actually, there are other countries per capita that actually per doctor make more money than Americans do. But that has to do with the mean. It has to do with the differences in specialties and proceduralists and, all that stuff. But that's a question that I think we need to ask ourselves, because we're running out of money. I mean, Medicaid's is projected to not be able to pay its bills, Social Security, entitlements, all that other stuff. Then there's the issue of social determinants of health and how much of a social support network should the United States have? Now, these are all big, huge political,
very big questions.
Yep. I'm not going to answer them on this program. But the point is, you and I both know that it has more to do with your zip code than your DNA as far as how much resource you're going to use in a sick care system. Well, that's a reflection of a safety net. And having worked at a safety net, and you have too, you've been there, it's a revolving door. You send them out, they're homeless, they come back 2 weeks later with the same problem over and over and over. And whether it's a food desert or a pharmacy desert or lack of income or whatever, I don't know what the answer is, but we're not doing a very good job of managing. And that's what I mean when I say it's a multi-systems engineering problem. It's a social problem. It's an economic problem. It's a political problem. It's a healthcare problem. They all affect each other. So that means you got to have somebody who can lead the change. And, with every major social movement, you could pretty much name the person that named the change. But whether it's civil rights or whether it's gay rights, or I don't care what you call it. So we have to do something different to create true, what I call leaderpreneurs. And a leaderpreneur, and that gets to this whole issue of leadership training for doctors, which I think is another waste of time. It just doesn't work. Just look at the history.
Yeah, we touched on that a little bit. It's sort of the parallel or to the MBA thing.
Right. It just doesn't work. I mean, the healthcare reform has been 100 years war. We've been doing this for a very long time. And there's a whole literature about why it's just not doctors, why leadership programs fail. But the main reason has to do because most of them are not experiential and you don't suffer the consequences of your decisions. So we need to do a better job but we can't just manage innovation systems. We need how to learn to lead entrepreneurs. It's innovators. It's a different mindset and a different skill set, which brings up the whole issue of what are healthcare management programs doing, health administration programs? Because I work in some of those too. Those folks really are really stuck in these functional domains, and they just don't have a big picture leaderpreneur mindset.
Well, again, the change is not going to come from within. So, those programs are designed to perpetuate the system that they're building, not to change it.
Well,
so.
Not the least of which is they're misnamed because A, it's not a healthcare program, it's a sick care program, and B, we need more administrators like a hole in the head.
That's
so
sure.
maybe they need a branding expert to change the specialty name or something. But.
Yeah, maybe there's, well, good. So what would be some of again, we've gone through a lot of things and there's not one answer, but if you were going to name the 3 things that if you could have happen tomorrow within the whole realm of everything that we've talked about, what would be practical things that you would say tomorrow we could actually do this if we set our mind to it?
Number 1, reform medical education. We doctors and the medical establishment are the people who do that. So we created it, we can change it. Number 2, I think we need to rethink the accreditation criteria because let's face it, medical schools create the curricula that they do to comply with accreditation criteria. If it's not on the test, forget the rest.
Yep.
So if you want to make this something that you have to do, you have to change the accreditation criteria. Either do it or we're not going to approve your school. Now, the latest ridiculous example is mandatory nutrition education in medical schools, or we're going to revoke your grants. I mean, that's totally ridiculous as far as I'm concerned for a gazillion different reasons. But it's an example of people trying to stuff things into the curriculum and political motivation. But that's a whole other story. But so those are a couple of things. I think we need to rethink how we do a better job of getting in touch with the stakeholder base. That is students, pre-meds, that kind of stuff, and how we recruit students. I think we need to give them more exposure to the things I've mentioned during this program in terms of to non-academic tracks and supplementing clinical medicine. I'm not saying don't sacrifice teaching people how to be competent doctors and instead teach them how to just to be business people. That's not what I'm saying. I'm saying you have to do both. And you're not doing, I frankly think that not teaching the business of medicine is a real disservice at best and educational malpractice at worst.
Couldn't agree more, honestly. I think, the pendulum analogy is always used, but we have swung so far away from, again, in my view, that connection between the doctor and the patient and the way to deliver that care that all the things that you've mentioned are certainly things that would affect that.
And the final thing is, and obviously it's self-serving, but the point is we need to do a better job of engaging formal education with the hidden curriculum and the parallel curriculum. And by that, I mean organizations like the Society of Physician Entrepreneurs. These are collaborative online innovation networks that have nothing to do with medical schools. They're independently created to fill the gap. That's why we created it, because it wasn't being done in medical school. So we, meaning several of us, decided to do it and offer this education and access to resources, networks, mentors, experience, peer support, non-clinical career guidance to people who want to do it, but are not being offered it by the medical education establishment, of which I am included. I am one of those people. Nothing worse than a reform sinner. I'm trying to fix that.
Yeah, that's a great resource. And for our listeners, the SoPE website will be available in the written.
Yeah, thanks for sharing that at www.soapnet.org. Yeah, we have chapters. It's an international nonprofit. We have chapters all over the world.
In addition to the SoPE website and your writings on LinkedIn and other sources, can you tell us a little bit about sort of where would somebody look for input from other industries, other specialties, other ways of thinking into, that would inform them again about options that they might have, or to be able to develop some of the ideas that they might have?
I mean, everybody has a different interest. Again, drugs, med tech, AI, digital health, whatever. And each of those are separate ecosystems. So my advice is just simply sign up for any kind of newsletters that have to do, and there's a gazillion of them and they're free. So just get information every day outside of your domain. And secondly, if you're interested in the business of medicine, then just subscribe to the Harvard Business Review or Kellogg or Wharton or anything that or the Wall Street Journal, or anything that provides you with business education and business speak, just so you begin to understand the basics and the language and the jargon. So, and it's entirely up to you. I practice what I teach. In other words, I write a lot of stuff. And I'm not talking about academic stuff. That's stuff that we all do because we're academics. I'm talking about business stuff. And I mean, if there's this thing, if you're going to write, you got to read. And so I, on a daily basis, download probably, I would say, 8 to 10 different sources of information from different industries to inform my thinking of how it applies to medicine. So I would suggest to a person that wants to get started, pick one and just read it every morning. And then if you like that, pick another one and just, think big, start small. The issue is not which resources should you access. The problem is that people don't do it. They know they can get this stuff, but they're not sufficiently motivated to actually do it. My back of the envelope, there's about 1 million practicing clinicians. About 1 to 2% of them, and actually I include all white coats, engineers, scientists, graduate students, you name it, dentists, doctors, pharmacists, nurses. If you take all those people together, I think about 1 to 2% have an entrepreneurial mindset. You have to have this drive, and you have to have this, what I call, make it personal, but don't take it personally, which means there has to be this voice in your head that is driving you to move to the next level and develop these competencies so you can solve the problem you want to solve.
Absolutely.
So in addition to what I just mentioned, I would say that if you want to get started down this physician entrepreneurship road, you're basically going to need what I call the 4 or 5 M's. That means mindset, motivation, means, metrics, and monitoring. Motivation, I've talked about. Means is, it could be money, it could be people, it could be just a place to work, it could be access to getting experience or something like that. The metrics has to do with, there are certain competencies that you need to develop that are unique and distinct from clinical competencies. And there are many, and we can enumerate them in my articles and all that other stuff. But the point is, if networking is one of the competencies, let's just pick that. Most white coats, including doctors, have very limited networks. And if they have networks, it's usually within medicine. And more specifically, it's within their own specialty. They don't talk to anybody else. let alone external robust networks, investors, entrepreneurs, business people, journalists, people that are outside of medicine.
Very good point.
So that's a metric. So if you want to develop this, for the next 3 weeks, add one person to your network that has nothing to do with medicine and connect to them and talk to them and engage them. That is a core entrepreneurial skill, networking, internally and externally. And most people don't do that because what they do is they practice medicine, they do clinic, and then they figure out, I don't want to do this anymore, but I don't know anybody else that can help me. Well, of course you don't. You didn't do anything to connect them before you needed people or they needed you. So that's an example. And then there's a whole list of other competencies, but you have to have a personal and professional development plan that lists the competencies. It's like Benjamin Franklin's autobiography. You know, he had 7 virtues. He practiced one every day of the week. That's what you need to do. On the y-axis, what are the competencies you need to learn? I need to learn how to read basic financial statements. I need to expand my network. I need to connect to someone who may be able to offer me experience working in a startup. I need to understand sales and marketing. I need to understand artificial intelligence at a basic level. And I'm going to do this one on Monday and this one on Tuesday and this one on Wednesday.
Sounds like a good week.
It's fun. I like it.
Very good. Well, Arlen, it was really great speaking with you. Thank you for being our guest. It covers the topics that are really very near and dear to the mission of IndeDocs, which is to promote, protect, and preserve the independent practice of medicine. And certainly your comments are very salient to that.
My pleasure.
To our audience, thank you for joining us. Please make sure to rate and follow the podcast, as that really helps us to grow this community and spread the word about the issues we've explored. And please tune in next time for another great discussion about independent medicine in South Carolina. From all of us at IndeDocs, take care and stay well.
Thank you for tuning in to this episode of the IndeDocs podcast. Our producer is Jenna Leaf. Promotional support by Uplift Marketing. Mixing and mastering by Noah Martin. Content editing by Jenna Leaf. Additional production support by Noah Martin, Rebecca Lockhart, John Robinson, and the IndeDocs Board of Directors. For more information, please visit us online at IndeDocs.com.